Hello, we are the health science major students at Coppin State University in HSC 404. Thank you for joining us for Medical Ethics Conversation with Students Podcast. I am Danielle. This is Deja. This is Jerica. And this is Mackenzie. Today, we are discussing end-of-life care and should a patient receive nutrition. And what is end-of-life care? End-of-life care is a term used to describe the support and medical care given during the time surrounding death. This type of care does not happen only in the moments before breathing ceases and the heart stops beating. Other people or older people often live with one or more chronic illnesses and need significant care for days, weeks, and even months before their time of death. The end of life may look different depending on the person's preferences, needs, or choices. Some people may want to be at home when they die, while others may prefer to seek treatment in a hospital or facility until the very end. Many want to be surrounded by family and friends, but it's common for some to slip away while their loved ones aren't in the room. When possible, there are steps you can take to increase the likelihood of a peaceful death for your loved one by following their end-of-life wishes and treat them with respect while they are dying. I have a story about Mina. Mina is 80 years old. Mina had been in a nursing home for 2 years following her stroke. Eventually, her health declined and she was no longer able to communicate her wishes. Mina's physician, Dr. Torres, told her family she was dying. She said that medical tests, physical therapy, and treatments were no longer needed and should be stopped because they might be causing Mina discomfort. Also, they would not interrupt her rest, Dr. Torres said. The healthcare team would stop regularly checking vital signs such as pulse and blood pressure. Then Mina developed pneumonia. Her family asked about moving her to a hospital. Dr. Torres explained that Mina could not get the same care in the nursing home and that a move could disturb her and confuse her. The family agreed and Mina died 2 days later in familiar surroundings with her loved ones present. End-of-life care can also include helping the dying person manage mental and emotional distress. Someone who is alert near the end of life might understandably feel depressed or anxious. It is important to treat emotional pain and suffering. You might want to contact a counselor, possibly one familiar with the end-of-life distress, to encourage conversations about feelings. Medicine may also help if the depression or anxiety is severe. End-of-life nutrition. We are often asked, what should we do? Our loved one is not eating, and our answer is almost always the same. Does your loved one want to eat? As our loved ones approach the very end of life, their quality of life, the relief from sometimes painful symptoms, and comfort care are of utmost importance. It is at this time that we need to carefully listen to our loved ones and determine their major concern. If your loved one is not asking for food or drink, if they are not completely refusing food and drink, then most likely they are not hungry or thirsty. It's sometimes difficult for us to understand and let go of instinctive habits of feeding and comforting the ones that we love. We feed and nurture our young from the minute they are born. However, in most circumstances, it is us, the family and friends, who would be most comforted by seeing our loved ones eat or drink. Sometimes it's easier to accept this if we understand the process of nutrition at the end of life.
Food and drink are basic physical needs with psychological, social, and symbolic significance. In the last days of a patient's life or hours, they become less able to refuse to eat or drink by mouth. The patient have the right to be supported to eat and drink safely for as long as they want. However, the question of whether to provide clinically assisted nutrition and hydration, defined in law as medical treatment, has long been debated. The phase of end of life refers to patients likely to die within the next 12 months, and the term dying to patients in the last days or hours of their life. If a hospice patient body is shutting down, then you don't need to give them advanced directives. If the patient is not asking for food or drinks, then you shouldn't give it to them. It's a common knowledge when a patient refuses to eat or drink, their body is preparing for death. If you force feed them while their body is shutting down, the body will feel exhausted from using that energy and the patient can't rest properly. Force feeding them can cause vomiting, diarrhea, edema, or constipation. Patients with life-limiting illness, nutritional requirements changes. They need fewer calories and their appetite and desire for food decreases. Nutrition support at the end of the life does not reverse or cure a disease. It's important to explain this to patients' families. The pros of clinically assisted nutrition and hydration are preventing thirst, delirium, hypoglycemia, but it increased the risk of aspirations because of feeding tube, pressure ulcers due to diarrhea, infections, and discomfort. Patients may not tolerate tubes well due to discomfort leading to restraints to prevent from pulling them out. Tube feeding has cons such as losing the taste and textures of food and the social and human contact that comes with being hand-fed. Some patients get dryness of the oral cavity with being thirsty, and this can be fixed with lip moisturizing and mouthwash.
I strongly believe that at the time of death, patients should receive nutrition unless they've indicated that they no longer want to receive nutrition and absolutely refuse to accept it. If a patient did not refuse to receive nutrition, it should still be given because food and drinks are a basic necessity to human life. But in some cases, depending upon how ill a patient is, I suggest the patient should receive minimum amounts of food and drinks. It might not have much of an impact to increase the patient's life expectancy or illness, but the person is still alive and should still receive the basic necessities of nutrition. Although the patient's body begins to shut down and prepare for the end, I do strongly believe the patient still needs to receive proper care and not the bare minimum because a miracle could possibly happen. I also believe a patient should receive an advanced healthcare directive. This is to ensure physicians, family, and friends know the patient's healthcare preferences, including the type of special treatment the patient wants and does not want at the end of their life. Someone who is alert near the end of life might understandably feel depressed or anxious. It is important for patients to receive proper care during the end of life because it may help the dying patient manage mental and emotional distress.
So I have some questions for you guys. What happens when they no longer want to feed them tube? Because you can either, as
Jerica?
as Jerica said, some people are being head fed, but some people are also being using feeding tubes. So what you guys think about that?
It's ultimately up to the patient, especially if they're alert and they have a good understanding of what's going on around them. I feel like it's up to them to decide whether or not they want to continue with the feeding tube.
I also agree with Danielle. I feel like most patients who come to the end of life, they are tired, honestly, of fighting. They don't see anything worth living for anymore, and they have no hope. So there's nothing you can do once, they refuse to not accept it.
Yep. If they don't want feeding tubes, don't they have capsules, food capsules they can take?
Sure,
That's a possibility. I'm not too sure, but
yeah, I know. I think my godmother, when she was in the hospital, she couldn't breathe because she had a procedure done. So they ended up putting a tube down her throat, but that tube actually caused more damage than it did helping her. So once they took that tube out, because it was in there for so long, it's like her throat was closing up around it. So once they took that out, she had a hard time breathing because her throat was too small. It was weird. I don't know. But.
Yeah, that's also something to think about too.
As Jerica also said, we have feeding capsules. What do you guys feel about artificial nutrition?
I'm guessing the artificial, what you say? The artificial nutrition, it gives the nutrients that's needed, but it could be the taste and the texture of it that people don't like.
And it might not satisfy them.
What I read from Kelly and Amy at the Hospice of Huntington, they said terminally ill patients generally don't experience hunger, and those who do need only a small amount of food to alleviate symptoms. So it's not like they need constant nutrition throughout the entire day. It's just to subside those, like the feeling of being hungry.
So what happens if the only option is the feeding tube? Then what happens if the advance directive is don't put a feeding tube in me? I don't want a feeding tube. So if that's the only option? How do we go about continuing that? Like,
I would say explain to the patient what works best for them, and in some cases, once it's the end of life, a lot of patients are, I guess they stick with how they actually feel, and there's no way to talk them out of it. So if I said before, if the patient refuses, it's really nothing you can do. You can't force them to take anything that they don't want to take, because sometimes it could be like religious beliefs and other things like that. So you can't go against it.
Yeah, because at the end of the day, you gotta do what's best for the patient and what they want.
And sometimes it might not be what's best for them, but
Even if they don't verbally say it, but they're telling you somehow, like physically, or if they write it down, you have the physician has to go by what that patient wants. And again, like if they're not alert and they don't understand what they're doing, then that's a different story. But if they are expressing how they feel, whether it be verbally and doing it through hand movements or anything like that, you still have to go based off what the patient wants.
so when do you guys think the ethics committee should come in if they can't, verbally tell a person that, hey, this is what I want to happen, or if they can't communicate it like in a vegetable, type state? Then what are we going to do? When does the ethics committee come in?
So I know from personal experience when my father, we believe that he had a heart attack, and then, so he was found outside, and it was like he was trying to go ask for help because he was experiencing it wasn't his first one, and he ended up collapsing and being unconscious for more than 15 minutes. And after that, the blood or the oxygen to your brain is no longer flowing. So once he got to the hospital, he was in the hospital for like maybe a week and a half, 2 weeks, 2.5. It was a long time ago, but it was a hard time. But he ended up being brain dead. So the person who basically needed to decide whether or not to pull the plug on him was my older brother. But instead of it, like all the pressure being put on him to decide whether or not to basically kill Dad, we had a family meeting, and I believe that the ethics committee came in and talked to us about, so if we were to keep him on the ventilator, this is how it would go, and if we were to take it off, obviously that. So I mean, if you're not able to come up with a decision by yourself or even with the family, the ethics committee should come in to give you options and guide you on what to do next.
And in some cases, like, what if that doesn't even help? What if the family or friends cannot still come to an agreement? Then what do you do from there? It's just like,
I feel like it's just a cycle that won't end if they don't come up with something. They also have to think about what's best for that patient. Like, if you keep him on the ventilator, is it the best thing to do for him? Like, will he continue to suffer the way that he is? Will he feel pain? Will he get out of that? Like, will they have to, once they pull that ventilator, is he going to be able to breathe on his own? Is he going to be able to eat, care for himself? Like, they have to consider all of those little details before they make that big decision. Because that big decision could affect, like, it'll be with you for the rest of your life. Like, if you were to pull the ventilator and he starts breathing on his own, that's good. But if he starts breathing on his own, does that mean that he'll be able to walk again, to eat by himself again? You know what I mean? His normal activities that he used to do.
Mm-hmm.
And if they don't, if they pull the ventilator out and he's not able to breathe on his own, and you keep him on that ventilator, is he still going to be in pain?
That is something to think about. It is. But sometimes in certain cases, I personally feel like there's still a possibility in certain situations.
Yeah, I agree with you. It's always, like you said, there could be a miracle.
It can.
And it has happened before.
Oh, and it has.
And
it hasn't.
personally, I feel like if we would have kept him on that ventilator and waited a little longer to see if he'll get better, if he would be with us today and how he would be.
Mhm.
Like, would he be his normal self? But again, like, he didn't have any brain activity, but I still feel some type of way, just a little bit. Like,
Because
he
I
was
feel
still
like
there.
sometimes when they don't have brain activity, they can still look. It
Yeah.
can kind of like indicate something. So it's
Mhm.
like something is working. We just don't know exactly.
Exactly.
So is it still time to pull the plug or
Mhm.
say, okay, you know what, this person really doesn't want to be here anymore? You don't even know that. You don't know
Yeah.
that at times. So it's like sometimes it's good to like wait it out.
I also think that's why it was hard, because
How long should we wait it out?
that's a good question.
That is a
That's
good
a good
question.
question.
Because you don't know. It's like when people have illnesses, it lasts for so long.
Mhm.
It could be years from now, and then somebody can show you a sign. And you're like, oh my gosh, I'm glad I didn't do it because this person is responding now.
Mhm.
It's like I guess you have
Like-
you have to progress.
I think
I think
Because
that's
I-
what it is.
I remember your story about your father saying he was crying.
Yeah. So, like, the things that we would say to him, be like, well, you know, you just need to fight. You need to hold on a little bit longer. And I would see tears, and I would see him blinking, like moving his eyes a little bit. But the doctors always said, well, that could be a reflex. Like, it's like the doctors, they had hope, but very little. Like, us as family members, we had more hope than the doctors.
I feel like doctors see it so much,
Mm-hmm.
they get numb to it, and they're just like, I've seen this before.
Yeah.
Let's just cut it. It's no point.
Mhm.
I don't see no progress. But like I said, in certain situations.
And honestly, if they said that he wasn't going to be in pain, like, they gave him morphine at the end.
Mhm.
Morphine is a really strong pain medicine. So if he wasn't going to be in pain, why are you giving him this? Right? So they gave him morphine. Once they pulled out the ventilator, they gave him the morphine so that he would be able to pass without pain.
Mhm.
So it's like, if we didn't pull the ventilator out, would he have to be on morphine for the rest of the time that he was in the hospital? Because he was getting morphine the entire time. They just upped the dosage at the end.
Mhm.
So it's like, it's hard to think about, like, what to do.
Right. And sometimes the doctors aren't always right. They make mistakes too.
And I also feel like you can have all these advanced directive or power of attorney, people like that in your circle, but you also need people that like actually know you, like actually like live with you for the past 5 years before the incident happened, so they understand like, hey, this person might not want this treatment, or this person might not want, they want that treatment. So you have to just understand the person that you're dealing with, and not everybody deserves to be in a conversation, but people, it's okay to have, people different.
Yeah, there's always that one family member who think they know the best.
They
Yes,
just
I
don't.
think
And that's why sometimes it's hard to balance. Like,
Mm-hmm.
what's
it's
this
just
is?
be your immediate family,
Right,
like your
exactly.
mother, father, your kids.
Yeah, I think we had more than that at the hospital. It was me and my two siblings. It was my mom. My mom was the ex-wife. I was her best friend. And then we had his brother, his sister, and a couple of his nieces and nephews, my cousins. Like, it was all a family matter because he was so important to us. We wanted to make the right decision. We wanted to get everybody on board.
Right.
And so we ended up deciding that we don't want him to suffer anymore. Like, we literally, it was like a room like this, and it was all of us in there. It was the doctors, and I'm pretty sure the ethics committee. And we just went around the room, and how do you feel? How do you feel? What do you want to do? And we decided that we don't want him to suffer anymore. We're going to pull out the ventilator. But I still do want, it's been 7 years, but I still wonder if we were to kept him on that ventilator, would he still be here? Like, no matter what it was, they said that he had like a less than 2% chance of knowing who we were.
Mhm.
So it's like, even if we kept him on that ventilator, he wouldn't know who we were because of all the brain damage. So that's something to think about too. Is that it?
Yeah.
That's it. Okay, well, thank you guys for joining the medical ethics conversation with students podcast, and we'll be back in a couple weeks to discuss another topic.
Thank you.
Thank
Bye.
you.